Good evening, everyone. Good evening. Good evening and welcome. My name is Peter Wood and I am the chair of the New Zealand Multiple Sclerosis Research Trust, and it's my pleasure to welcome you here tonight. A special welcome to those that have come from outside Auckland. It's great to see you here. We have some apologies. Tim Preston and Kate Russell, who are past chairman of the Trust. Sir William Geller, who's our patron, has apologised, and also Dr. Samantha Holdsworth from the Mātai Research Institute has given her apologies. I acknowledge here tonight the fellow trustees of the Trust, the executive of MSNZ, and Amanda Rose, the executive officer, also the representatives from MS from around the regions who are coming to the conference of MSNZ over the next couple of days. We also have some of our recipients of grants that have been given by the Trust over the last 10 years, and people from Mātai Research Institute here with us today. The couple of housekeeping matters. If there is an emergency, there are signs around the places to the exit, if you could follow those. The toilets are out on the left side of the building over there. As you're probably aware, this is 10 years now that the Trust has been going. We were formed in 2015, and it was the concept of Neil Woodhams at that time that formed the Trust. He was the president of MS Auckland and the Vice President of MSNZ, and each of those organisations had funds which were dedicated to research, but neither organisation really had research as their core objectives. Their objectives were looking after the people in their regions or in New Zealand that had MS. They also didn't have enough monies individually to really make a difference in research. So he saw that the forming of a trust which had its core objective being research and combining all the funds would make a difference in New Zealand. And that's what happened in 2015. The trust was sponsored by MS New Zealand, who contributed $600,000, and MS Auckland, who contributed $300,000 to get the trust up and going. So over the last 10 years, we've used those funds to give grants to 32 different organisations, and we've given grants in excess of $700,000 over that period. The first grant we gave was to the Waikato Hospital and Waikato MS organisation to get MS Base, get patients in New Zealand with MS onto MS Base. And MS Base is an organisation hosted in Australia which has a database of the anonymised patient records for patients throughout the world. At the moment, they've got over 120,000 patient records from patients in 45 different countries on their records, and that provides a world-class database for any person in the world to research the progress of people with MS. And MS Waikato and the Waikato Hospital have contributed to that database over the last 10 years, and their patients that they've had there have had over 19 different research activities undertaken using their patient information. So it's a very valuable resource that's occurred over that time, and they continue to support. They're looking towards Auckland Hospital, Wellington Hospital, Christchurch Hospital, Rotorua Hospital to try and encourage them to come onto the MS database. And that's one of the core objectives of our trust, is to get as many patients as possible from New Zealand onto that database so that they can be part of the worldwide research organisation. And over the last 10 years, our last and current grant that we've made is to the Mātai Research Institute for research into their Ultra High Contrast MRI. It's a really great project that they're doing, and one which is going to have impact not only in New Zealand but right around the world. And as well as using our own monies over for projects, this is a typical example of what we do, is use the core money that we have to also leverage other organisations to come forward. So as part of their research, the Mātai Research Institute have their own monies going into the project, and the Williams Family Trust in Gisborne is also contributing to that project. So by having the base fund from us, grant from us, they were able to leverage these other organisations to come forward. So we see that part of what our monies can do is not only to use our monies, but to leverage and use other foundations' monies for research purposes in New Zealand. So that $900,000 has now grown to over $2.2 million after all that $700,000 of research funding that we've done. But research is a very voracious appetite, and we need more money all the time, and the more money we can get donated and contributed to us, the better we can be. So it's great to have you here tonight. So I'll ask Neil to come up and MC the rest of the evening with our guest speakers.
Thank you, Peter. I think that deserves a round of applause. I think, if I can just add, very clearly what this indicates is that the MS community, one, has an intense interest in research. One of my key objectives was to support clinicians, both doctors and nurses and researchers, who wanted to work in New Zealand but needed access to research funds. And you're going to hear tonight from two, younger than I am anyway, clinicians, researchers who have got exactly that in mind. And when I first met Dan, he said if it wasn't for the Mātai Research Institute, I wouldn't be working in New Zealand. And so we have a number of factors. Obviously the research is important, but also ensuring that people who are interested in research can easily access funding. And that's a key thing, and it's great to see it happening. I'm going to ask Dr. Ernie Willoughby, who won't need much introduction to any of you here. Ernie has a very distinguished MS research career. In addition to being a preeminent MS neurologist, Ernie's name sits on well over 200 peer-reviewed research papers on MS and other interests. And I've asked Ernie to introduce our first speaker, Dr. Daniel Cornfeld.
Thank you, Neil. You want to sit somewhere where you see the slides?
I was very concerned.
I don't have any slides. I was going to reinforce the comment that the successful establishment of this research trust is very largely due to the energy and enthusiasm of Neil. He's run the whole show in many respects. And I would note our speakers tonight give an indication that practical research in MS can be done in New Zealand, and the Trust is keen to support that. Both of the speakers are involved in this new, innovative, very exciting work on MR scanning based at Mātai and Institute in Gisborne. Dan Cornfeld is the clinical and imaging head there, and Dr. Benson Chen, who works in Auckland, is involved in assessing patients for the scanning trials, especially those presenting with a first attack of optic neuritis, and I think you'll hear more about that. First up is Daniel Cornfeld, who you will soon detect is an American, with a pretty impressive CV for someone in Gisborne, I must say. I'm from a small town, so I can make jokes about small towns. He completed his bachelor's degree in physics at Princeton University. Says he doesn't remember much about it now. His medical degree at the University of Maryland, and then developed his expertise and interest in research and MR scanning as Associate Professor of Radiology at Yale University. and he moved to New Zealand, to Gisborne, in 2015. As I said, he's currently clinical and imaging lead at Mātai and head of radiology at Gisborne Hospital, where I think he's the only radiologist. Dan's topic is UHC, meaning Ultra High Contrast MR, which is a new technique for diagnosing MS and other neurologic disorders. Dan.
That was very nice. For all those accolades, I'm Samantha Holdsworth's replacement tonight. All right, so I'm going to talk maybe a little over 30 minutes about ultra-high contrast, which is a technique we've been developing at Mātai. And this is a view of Gisborne from one of the little local hills. You have to be careful walking up because there's a lot of mountain bikers, but that's the beach where I surf in the morning, and the hospital's back over here. It's a beautiful, small little town. You can drive across the town in 10 minutes. So I came to Gisborne from Yale New Haven Hospital, which is a 1,600-bed, level 1 trauma center, cancer center, stroke center, children's hospital. Pfizer had a drug developing building just around the corner, and there was PET CTs. And so I left that because I wanted just to be a clinical radiologist. And when I moved to Gisborne, that's the hospital. And that's a lot smaller of a hospital. And that was 10 years ago. And then probably 5 years ago, we started thinking about forming Mātai. And, you know, it's like that scene in The Godfather 2 where, like, he says he's trying to get out, but he keeps getting pulled back in again. I tried to get out of academic medicine, but I just kept getting pulled back in again. And I'm kind of glad that I did, because the things you do when you're trying to develop new techniques and make a difference, it's a different part of your brain than when you're just saying appendicitis, diverticulitis, concussion, whatnot, and so forth. So disclosures, this new project is receiving funding from you guys, so thank you very much. Other than that, if anyone wants to supply funding, I'm happy to add your name to my disclosures list. I want to add that what I'm going to show you today is ongoing active research, so none of this is medical truth. A lot of what I'm showing you is anecdotal, meaning we very strongly believe that we're onto something, and the project that I'll tell you about is to show that it is actually something. So bear in mind, like, it's okay to be skeptical, it's okay to ask questions. If you just accept what everyone tells you about new techniques to asking questions, we end up developing techniques we haven't completely thought through. So if someone has a question about why does it do this, why does it do that, please ask. It's not going to offend. It's really only going to help. And the last thing I want to say is that our lead MR technologist, Paul, he developed a lot of these sequences. He took the theory and put it on the scanner. A lot of the pictures that I'm going to show you are patients that he scanned, that he recruited through local resources, and he deserves a lot of credit for what we're going to talk about here. Okay. This was a list of the supporters that got us to this point, and in subsequent talks we'll be adding your organization to this list because you're getting us past this point, which is fantastic. So ultra high contrast. All right, so this is a name we came up with, and it's a little tongue-in-cheek, and I'll explain why. But, you know, 50 years ago, all we had were X-rays. So contrast is how one tissue looks different from another, all right? One tissue's dark, one tissue's bright. The difference in brightness is the contrast. So contrast is how easily it is to distinguish one thing from another thing. And I'm really going to try to explain why this technique works, so you don't just walk away saying, oh, they're doing all these cool pictures. I want you to know what the pictures are showing and why they're showing it, because then you'll be even more excited. So with X-ray, take an X-ray of the brain, all you see is the bone in the air, right? You don't see the brain, right? So there's no contrast in the brain on an X-ray. So we're going to call that low contrast. Then we developed CT, and you could see the fluid in the ventricles, and you could see the white matter is a little darker, and the gray matter is a little bright, and this was the greatest thing. This was high contrast. Now we can tell the liver from fat, and kidneys from adrenal glands, and we can tell gray matter from white matter. And then when MRI came in, that was called very high contrast. Wrong way. Very high. And now, like, there's actually, you can see the different parts of the white matter and the different parts of the gray matter, right? And MR is touted as having great soft tissue contrast because I'll show you on other slides, when you look at the shoulder, you can see the different parts of the shoulder. When you look at the liver, you see the different parts of the liver. When you look at the brain, you see different parts of the brain. And then the technique we've developed, and I'll explain why these look like this, we're calling ultra high contrast. And it's kind of like we went from here to here, and it was a generational leap. And from here to here, it was a generational leap. And from here to here, we think it's a generational leap. I'm going to show you that regular MRI is very good at showing differences between different types of tissues. And that's a really important thing to do. And ultra high is a technique that we think shows you very small changes from normal within a tissue. And I'll explain the difference in that and why that's important, right? Ultra high is a bit of a tongue-in-cheek name. One, it's nice to go from high to very high to ultra high. The next will be uber high, and the next will be ginormously high, right? So we already know what the next ones are going to be called. But when you're buying a scanner, a research scanner can be a 1.5 Tesla scanner or a 3 Tesla scanner or an ultra high field strength like 7 Tesla or 11 Tesla. And then when you look at the gradients on your scanners, you can get the normal gradients, the good gradients, and the ultra fast gradients. And the tongue-in-cheek is we get these images on normal scanners with normal hardware and normal software. So you don't need an 11.7 Tesla research scanner with ultra-high field strength and ultra-high gradients to get this ultra-high contrast. So that's kind of like, when we see the name, we giggle because we kind of think like we're elbowing the vendors and whatnot. And the core of that is, if it works on a normal scanner, you don't have to have a great scanner to do this. So the hope is this will be translatable to scanners that already exist, so you don't have to buy new things to use these. All right, so 5 minutes on contrast. Right, some images are useful because they show you the difference between different tissues. Right, so this is the liver, and I can do over here too. Right, so these are like bread cutter axial slices through the liver, and I'm showing you liver metastases in a liver. Okay, I'm showing you colon cancer metastases in the liver. Right? So the liver is made of liver cells, and colon cancers are made of colon cells, right? And they are different tissues. They have different properties. They image differently. So to see something metastatic in the liver, you're looking for something that's liver compared to something that's not liver. And MR is very good at showing you the difference between two tissues. So we're not seeing subtle changes in the liver. We're seeing tissue that shouldn't be there, all right? So in a shoulder, these are straightforward views of the shoulder, and there should be a black tendon that goes across from here to here. And when you tear that tendon, the gap is replaced with water or blood or hemorrhage, okay? Blood and hemorrhage water are different from tendon. So you can tell the difference because the tendon looks one way and the blood or the water looks something different. So you can see the tear because you're looking at two different tissues. You're not looking at subtle changes in the tendon. You're looking at one tissue versus another tissue. And in the brain, this would be an axial T2 image through the brain and a sagittal T1 image, and I'm showing you a hemorrhage in the brain. Okay, blood is different from brain tissue, so you can tell one tissue from the other. So MR is great at showing you one tissue from the other, right? But some images are useful because they show you subtle changes from normal within a tissue. So here I'm showing you a liver tumor. So like this is normal liver, and this is a malignancy made of liver cells. I don't remember if this is a focal nodular hyperplasia or if this is a liver cancer, but it's a neoplasm that's composed of liver cells, right? And on this image, it's really hard to see the neoplasm from the normal liver because they're the same tissue, right? They're the same tissue. And even here you can see it, but it's kind of hard to see. So we look for properties of the tissue that can show you subtle changes from normal. So the difference between this neoplasm and this regular liver tissue turns out to be that one has a higher blood flow to it than the other and has higher vascular permeability. So if we give IV contrast, right, the contrast goes in the blood, it goes to where there's more vascular flow, where there's more permeability, and you can see that subtle change from normal. Right, so we try to find a technique that shows us when normal tissue is acting just a little bit differently from the way that it should. These are two images of a patient having a stroke. It's a flare image on the top, and it's a diffusion image on the bottom. So in a hyperacute stroke, right, the infarcting brain tissue is still brain. It's not liver cells, it's not colon metastases, it's not blood, right? But in the acute phase, the T2 weighted image of the flare cannot show you that subtle change from normal. So we use diffusion. Diffusion imaging is a technique that can show very subtle changes from normal in tissue diffusivity, right? So in here I talked about blood flow, here I talked about diffusion. These are all examples of what we call tissue properties. So when the MR is taking a picture of something, we're actually measuring certain properties of the tissue. The common ones are called T1, T2, maybe you've heard of those if you've seen your own scans, but diffusion is a tissue property, susceptibility is a tissue property, blood flow is a tissue property, diffusion is a tissue property. And we try to find techniques that can look at subtle changes in these tissue properties, because we're not imaging hemorrhage versus brain, we're looking at white matter that's normal versus white matter that's diffusion properties, just a little bit different than it should be. Right? So ultra high is aimed at finding these very small changes in normal from tissues. All right? So we'll come back. So regular MR is excellent at seeing different tissues and kind of good at seeing subtle changes from normal. Ultra high is not very good at looking at different tissues. It's not designed to be, but it's excellent at looking at subtle changes from normal. Right? So again, we think it's a new paradigm. All right, so I'm going to talk about standard imaging in multiple sclerosis. I'm going to explain what exactly ultra high is, and then I'm going to show some examples in MS, and then I'll show you some examples of where we found it to be useful in other brain disorders. All right, so it's always hard to know how much imaging to show to listeners that aren't physicians or researchers, but I found that the MS community is pretty on the ball when it comes to knowing what their pictures look like and being up to date with the research. And so I'm going to maybe err on the side of going too complex, and if I do, bring me back down. But I don't want to dumb it down for this group. Okay. So these are all sagittal images. So they're sideways images of the brain, and this first one is a T2 flare. And it's mostly based on the property called T2. The middle one is a T1 weighted image, and the one on this one is a front, and it's a stir image. So the T2 flares are primarily based on the T2 tissue property. So if that's abnormal, you see a change. The T1 images are mostly based on the T1 property, and I'll talk about it in a bit. And the stir is actually based on both. And these are kind of the workhorse sequences for imaging in MS. I mean, I know that to look for active plaques, we could do diffusion, we could do tissue contrast, and to look for subtle residual inflammation, we use susceptibility weighting. But these are still the three mainstays. All right. So this is a graph that shows what our sequence is doing. So on this axis, I'm plotting the tissue based on its T1 tissue property, and it's just a number. It's a number that describes how fast these tissues relax in a magnetic field. It's not important, right? Each tissue has a different T1 property. And this axis, I'm saying how bright that tissue will be on the scan, all right? And these graphs here are for normal T1 weighted images. So the blue and the red talk about how this image works with different parameters. And our sequence is the purple one. And what I want to say about this is, so what is contrast? Contrast is how much does the signal change when the tissue property changes. So if a really small change in tissue property can result in a big change in signal, you'll see it on the scan, right? If a really small change in tissue property does not result in a big change in signal, you won't see it on the scan, right? So change in tissue property versus change in signal is the slope of the curve, right? So for regular sequences, right, if this is the normal, for the blue one, say, if this is normal white matter, if the T1 of white matter changes a little bit, the signal goes down just a little bit. On the purple curve, if the T1 of white matter changes a little bit, the signal goes up by a lot. Okay, so the steeper the line, the more signal change you get for a really small change in tissue property, which is what we want because we're looking for changes from normal. So it turns out that this graph is 5 times the steepness of the other graph. So just by putting a sequence that follows this curve, we've increased our sensitivity by a factor of 5, right? So we use a technique like this when we're looking for focal changes. And one thing to notice, it's set up so that normal white matter is dark, and changes in white matter become bright. That's different from what you normally see in a T1 weighted image. In a T1 weighted image, normal white matter is bright, gray matter is dark, and then abnormalities, this would be a Dawson's finger, so a plaque coming off the corpus callosum, is dark. On our series, right, the white matter is black, not bright. The gray matter is dark, a little brighter, and the abnormalities are bright, not dark. Okay? So it's still based on that T1 property, but it looks different than a regular T1 image. So if I show this to a radiologist at Auckland City Hospital, let's say, this doesn't look right. That's not a T1 weighted image. But you notice a couple things about this. The white matter is black, abnormalities are bright, and at junctions between gray and white matter, you have these high signal lines. And I'm telling you this because I'm going to teach you how to read these images, because in addition to them being translatable to other scanners, I've also taught all of our grad students how to read these because it's really easy. It's really easy. Like we used to joke, so I can say this because I've told this guy who invented it. Like, so anyone know what T2 flare stands for? It's a really sciencey name. Anyone? All right, so technically it stands for fluid attenuation inversion recovery. The IR stands for inversion recovery. To me, it stands for idiot radiologist because it makes the abnormalities bright. Okay? All right. So we can take that steep line, which was here, right, and we can make it narrower. And if we make it even narrower, we can make it steeper. And if it's steeper, it's even more sensitive. So when we're looking for focal abnormalities, we make that purple line not as steep as it could be. But when we want to see really subtle changes in white matter, we can make it even steeper and steeper and steeper and steeper and steeper. So when we do that, we find that normal white matter looks black, and then abnormal white matter, the whole thing looks bright, and then in the middle is intermediate. And we put this here, but I'll show you, we did like 60, 70 patients with this, and I think there were 3 or 4 that ended up intermediate. Okay, so we can make the white matter look bright because normal white matter is dark, and a small change makes it really bright. And that's really important. That's really important. Another thing to notice is that outside of this little window here, the signal doesn't mean very much, right? So this technique is targeted towards white matter. We could, in theory, change where this is located and target towards gray matter. We could find the T1 property of prostate, target towards prostate, look for small changes there. But for the purposes of this, it's all in the white matter. All right. Was that kind of make sense? Are there any questions about this? Okay. All right. So I'm going to raise more questions that these pictures raise than I'm going to answer questions. All right. So focal changes. Right. This was the first volunteer we had from Ty Rafferty who had known multiple sclerosis, and we chucked him in the scanner, and we just said, let's see what we see. So this is the T2 flare, and this is our ultra high contrast. All right. So the T2 flare is to look for plaques, right? Plaques are areas of high signal in the T2 flare, and supposedly they represent irreversible areas of myelin loss and myelin damage, okay? And if you look really closely, maybe there's something there, but you would never put that in your report. It's way too subtle. On the ultra high, there's clearly something right here, right? So the normal white matter is black, and the white means what? That T1 property has increased. And it doesn't have to increase a lot to make it really bright. So we first thought, all right, is this like a mistake? Right? Is there something wrong with this sequence? So we took her out, and we had her walk around the block. And then we put her back in, and we got the exact same thing. That was our first volunteer. So second volunteer. I know it's in the same place. That's really weird. Question? Oh, yeah, I'll go back and forth. Okay. Oh, no, good point. Let's go back. So for you guys over here, it's further away. It's going to jiggle a lot because, all right, so, right, there's clearly something abnormal in the white matter here, but you don't see it on the T2 flare, which is your standard, okay? So then, like a week later, we had another patient with the same diagnosis, and this one shows an abnormality in the same part of the left hemipons that the other patient did, but there's nothing on the flare, right? And there's nothing on the T1. Maybe the T1's a little bit dark, but you would not, like, you would get laughed at if you called that a lesion, right? So the question is, Are we seeing plaques with more sensitivity with this sequence? Which means if you were counting plaques, you would count more using this ultra high contrast than with the other one. Or are we seeing something different? Are we seeing something that maybe isn't an irreversible plaque yet? Maybe it's something that with treatment can be reversed. I don't know the answer. We've seen this in a handful of patients. But that's the questions that it really raised. And if they are like early, are they reversible? Right? And if we call them plaques, then can we make the diagnosis with imaging earlier because we'll see more areas of abnormality? Because if you look at the McDonald criteria, you have to have a certain number in certain places. So if we're seeing them better, can we make the diagnosis in someone who previously the MR would have been negative? And I don't know the answer to those questions, but that's what this makes us think about, because we think we're seeing things that we're not seeing with the T2 flare. And I don't want to suggest that this is better than the T2 flare. It's different than the T2 flare, okay? Because one, the T2 flare shows me things like the spinal cord, which is blurry here, and the muscles, and I can see the tongue and everything, and the lymph nodes, and anything outside of that narrow purple line that was straight is non-anatomic on these images. So you can't use it to look at the whole brain. You're using it to look at the white matter only. And sometimes things are really, really better seen on the ultra high contrast. Like this region here is much better seen than this region here, and I'll do it on this side too. So this region here is much better seen than here. But this subcortical plaque is much better seen on the flare, right? Like it's here, right? But only because, so this one here is there. But you only see it because you know it's there on the flare, right? So they need to be looked at together, right? Not suggesting replacing one from the other. Right? So how about in the spinal cord? So this is an image I took from a journal. So like when you're looking for plaques or lesions in the spinal cord, it's really hard because there's so many different T1 values of the white matter in the spinal cord that even your great STIR images, there's always some abnormal signal in the cord or normal signal in the cord that you didn't see on scanners from 10 years ago. So this example from a paper, right? So here's a plaque in the spinal cord. Here's a plaque in the spinal cord. There's one here and there. But like in the center part of the cord, there's this little band that's going up and down. So it can be really difficult with confidence to say you're seeing something in the cord. Right? And even on the T1, you don't see it at all, right? So here we are in that same first volunteer. So this is our sagittal the T2 flare. And, I don't think you see anything. Maybe there's something bright here, and here, and there. But on the ultra high, there's obviously some abnormal bright areas. Like, can everyone see that here and here? Right, so are we seeing the same thing in the cord that we're seeing in the brainstem, right? So is this a irreversible plaque that we've caught earlier? Is it something that's potentially reversible? I have no idea. But some raise interesting questions. So this was another person who carried this is just another example of the same phenomenon, right? So the T2 flare shows pretty much nothing. The T2 stir maybe shows something faint right here, right there. But the ultra high shows obvious areas of abnormal signal in the cord, right? Because normal is black and abnormal is white, right? So is it important? Yes, because in this patient, we thought that maybe there was a focal plaque here spanning 1 or 1.5 vertebral bodies, all right? But on the ultra high, there's a large area of abnormal signal, which is spanning 4 or 5 vertebral bodies, and a little bit of abnormal signal in the area postrema. So this is an MS distribution, and this is a neuromyelitis optica spectrum distribution. So did we change the diagnosis? Did we miss the diagnosis? Is there overlap in the imaging appearance between these disorders that we didn't know about, or are we sometimes misdiagnosing people? You're smiling. I don't know the answer, but like it's not nice when you see something and the books have said this is one, this is the other, and then you got someone who's classic for one and the imaging suddenly doesn't work. But that's why we do this, right? Who knows? All right, so I talked about all those things already. All right, optic nerves. Optic nerves are really hard to image, and we just did this was a patient who we didn't think had any optic nerve abnormalities, but optic nerves are mostly white matter, right? So the same thing works. Normal should be black, abnormal should be bright. So here you have a focal area of high signal on the ultra high image suggesting this patient has some abnormality in there, some T1 change. So is it demyelination? Is it just inflammation? What is it? I don't know. I honestly don't know if this person had symptoms of optic neuritis, but we saw something there. So we started doing higher and higher resolution images through optic nerves in patients. And this was a patient actually referred from Gisborne up to one of the clinics in Auckland and then came back down for more imaging. And what's really interesting here is, so this is the flare on the top and the ultra high on the bottom. And on the flare, the optic nerve should be dark because white matter is dark, right, on the flares. So on the right, it's normal. On the left, the posterior half of the vessel is abnormal signal. So on the right, it's normal. On the left, the posterior half is abnormal signal. All right? And then here it is just in the other plane. On the ultra high, the entire optic nerve is high signal, and the right remains normal. So I'll come over here, the entire optic nerve. So same phenomena, right? Are we seeing areas that, like, it's just too subtle to see the change on flare, but is this the same process? Is the back permanently damaged? Is the front reversible? I don't know. But that's what we're seeing. This makes us think we can see things earlier and see things earlier. It's kind of the same questions that they're all bringing up, isn't it? All right, diffuse findings. Okay, so if we make that purple curve really, really narrow, then we start seeing really, really subtle changes in T1. And we've been calling these subtle changes inflammation because that's like a buzzword and everyone talks about neuroinflammation. But the truth is, we don't know what might be causing that, right? If you look in the literature, there's dozens of primary and secondary cascades that happen in the white matter involving all sorts of different cell types and immune modulators. So we might not be seeing the inflammation. Maybe we're seeing like these different proteins or cells accumulating and changing the property of the tissue. I don't know. But remember, so what was normal white matter? Black, right? And the abnormal is white. So on these, I've outlined for you where the white matter is, all right? So which one is normal and which one's abnormal? Someone take a guess, come on. Okay, so, right, the top is normal, the white matter is pretty much black, and the bottom's abnormal, the white matter is pretty much white. Right, so the top's normal. So this is someone who's been controlled with their symptoms, and this is the same person when they had a flare-up of symptoms, right? So why is this important? Because as a radiologist, you count plaques, right? You count cortical plaques, and you count white matter plaques, and you say how many have diffusion restriction and how many enhance. But like MS is not a focal disease, it's an autoimmune disorder of the brain. It affects the entire brain. So here we think we're seeing when someone presents with acute symptoms, there's something wrong with the entire white matter, right? And the plaques just form at the end of some irreversible process, but the actual inflammation or whatever it is everywhere, right? So here we're seeing, someone normal when they're asymptomatic and when they're symptomatic. And I think the next slide is a different patient. This is a different patient with the same thing, right? So this is during their flare, and the flare is normal during the flare, but the ultra high again is completely abnormal. So what are these holes? These holes in the abnormal. So these holes are other plaques that you're not seeing also on the T2. Maybe not plaques, so there's other things we were seeing on the other sequences, other examples that might not be plaques. And why does it do that? Let me show why it does that. Okay, so when you have this really, really, really narrow, we call it window, where this purple line is really, really steep. So if the white matter increases a little bit, okay, then you get high signal. If it increases a lot, it can go past this point and start losing signal again, all right? So something that we think is a plaque or a plaque correlate or an early plaque or reversible plaque, their T1 properties changes more, and they end up on this side of the curve. So they look darker compared to the actual increased. And because there's this peak in the middle, they'll be surrounded by a high signal rim. So if you go back to here, right, what we think are these early plaques or reversible plaques, they're darker than the abnormal white matter because their T1 has changed more, and they're surrounded by these high signal rims. So here in someone with an acute flare, right, so here they are, dark with the high signal rims. So in this person with the acute flare, right, the white matter has a little bit of increased T1 property, so it looks really, really bright. Because we're using that really steep slope, right, these plaques, or whatever they are, right, their T1 goes up over that peak, so they look dark on a bright background, which is nice. We can explain that based on the way we know the sequence works. And they have these high signal rims around them. So not only is the standard not showing any diffuse changes, it's also missing all these little potential plaques or reversible plaques or early plaques or whatever the hell they are. Question? Pardon? Oh, okay. So traditionally on the images, like a plaque is an area of irreversible demyelination. So a place where the myelin's already gone. And that's kind of the standard thing that we look for on the images. Of course, like, we don't know what these other things are. We just know we're not seeing them on the T2 flare. Okay, so can we use ultra high to show diffuse changes during a disease flare? I just talked about that. All right, so we talked about these high signal boundaries, right, where one tissue abuts another tissue, and I'm not going to explain why it does that. But so we can take that high signal boundary in the gray matter, and we can look where it's discontinuous, right? So this is going to be an area where the T1 property of the cortex has changed, and this is a way to look for cortical plaques. So for years we thought that plaques only existed in the white matter, but we know they exist in the gray matter, and they're really, really, really hard to see. So we try to get thinner slices and more high-resolution images. And as a radiologist, going through all those cortical folds, looking for subtle little things is really difficult, and we probably miss a lot of stuff. But this is easy to see. Like this. It's just, it's straight and then it's not straight. So we think this could be a way to count cortical plaques. So we're about that. So where have we come here? So this is the paper, the initial paper from 1981 that said, patients with MS, you don't see anything on CT, and you see loads of plaques or white matter changes on a T1 weighted MRI image from 1981. Right? And now here we are, same authors, right? I mean, same last author, right? Bitter's there somewhere. Now we're saying, like, this was supposed to be the smart cousin of this. But this one shows so many more plaques or so many more white matter abnormalities and shows diffuse white matter changes. So this was high contrast, this was very high contrast, and this is ultra high contrast. Right, so it's showing us so much more. We don't know what these things are, what they mean yet, right? That's the purpose of the study, but it's showing a lot more things. All right. Is everyone want to go to the next, or do you want to see it in other diseases too? Because we'll show it in other diseases too. All right. So my biggest area of interest is, I started getting real interest in traumatic brain injury. And this was, where's this? Where's my other slide? Oh, it's missing. Come on. This was Josh's slide. Come on. Next. Oh, there was this great slide on here. All right, it's a great slide. So it shows one rugby boy, right, who's got a fractured vertebra. And it says, got hit in the game, has a fractured vertebra. Everyone can see it on the scan. All of his teammates are compassionate and hope he gets better. And the other one is, this kid had a concussion in the game, and the scan is normal, and it's 6 months later, and he still can't play. And all of his friends thinks he's a loser and doesn't have the heart to get back on the field. Right? So the issue with traumatic brain injury is head knocks can have lasting consequences, and there's no imaging that shows you've had evidence of injury from a head knock. And people get labeled as malingerers or faking, or they don't want to get back to work, or they're cheating the system. And even if you can just show them that there is something wrong, you've at least validated their living experience. But if you can then use that to get rehab paid for or rehab funded, you can direct these people back to where they're going. And TBI is a huge problem. It's not just sports. It's like car crashes, simple accidents around the house, domestic violence, right? All sorts of work injuries. It's really, really, really common, and a lot of symptoms don't go away afterwards. And the common, like moderate, severe brain injury is a lot less common than mild traumatic brain injury. So most people with a concussion have a normal CT. They don't have a subdural and have like normal. These are made with ChatGPT. Isn't that impressive? They don't look right to me. I'm not sure what these are supposed to be because ChatGPT made this. So one of my colleague Josh is showing these slides down in Parliament right now, actually, to try to get them interested in this too. Anyway, so what can you do with imaging? Oh, here it is. No scan heckled by peers, whatever. So we've thrown the same technique at people with persistent symptoms from a remote traumatic brain injury. And we find that the T2 is normal, and the flare is normal, and then white matter should be bright or dark. It should be dark normally, right? So they come in concussed and it's bright, and then they get better 2 weeks later and it's dark. So they come in acutely and it's bright, and then they feel better and it becomes dark, right? So the question is, does this mean anything? Are the people where it starts out bright, does it mean they'll be better in 6 months versus not better in 6 months? I don't know. If it started out this way and then it ends up being this way, does that mean they can go back to playing sports? We don't know. But we've seen anecdotally people present with acute symptoms and the white matter is abnormal, and then 2 weeks later they're feeling better and the white matter is suddenly normal. So we've taken a cohort of almost 70 patients. And these are people who have had remote mild traumatic brain injuries, and a neuropsychiatrist has said, this person's really not well. There's something they're not functioning properly. And we looked back at their scans, and being in the healthy versus symptomatic cohort really correlated with the scan white matter being white or the white matter being dark. And it's really pretty. This isn't even a real statistical plot. It just helps to show the difference, right? And it turns out that of these 3 people in the healthy cohort, these 3 were all in the same family, and the flu was going around their house. So we think that, you get a little bit of brain inflammation from being sick. Maybe the white matter can change too. We brought 2 of them back 3 weeks later, and the scan had normalized. But if you're showing the data, you can't pick what time point you decide to use it on, right? So we took the first time point. So we think that this could be very useful in showing that someone's had changes from a traumatic brain injury, and we're in the process of doing a more longitudinal study where we'll take someone at acute injury and follow them 2, 3, 4 time points and see if we can correlate the symptoms with the imaging and correlate initial imaging with eventual recovery. But that's a different study. Patients on chemotherapy sometimes act a little weird, and we know because we're putting poison in their brain, and some of it goes across the blood-brain barrier. So this would suggest that we're affecting the normal T1 properties of white matter when people are on chemotherapy. Again, it's just an N of 1, right? It's hard to recruit people for this. And even some neurodegenerative diseases, like Parkinson's. So all the other examples I've showed you, the disease makes the T1 go up, not down, okay? So Parkinson's, we think there's going to be some abnormal iron deposition in parts of the brain. And we always talk about the basal ganglia and the midbrain, but it's also the cortex, it's also the white matter. So if you start at the normal, at this purple curve, if you start at the normal T1 properties of gray matter, and then you decrease it, then you end up going up and coming back down, and you can have areas that are of equal signal or lower signal, right? So over here, if you start at the normal T1 properties of gray matter and decrease it, you go up over this ridge and then back down. And when you go up over the ridge, you get one of these high signal interfaces. So, and I'll do this on both sides, this is subtle. Like the normal gray matter and all the other pictures I've showed you, gray matter has 1 bright line on it. But this person with Parkinson's has 2. There's a separate line here, 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 here. I'll go over here too. It's harder to aim over here. But most of the gray matter has a single line, but where the arrows are, there's subtle high signal on the outside in the cortex. All right, we're calling that like the double bright line sign or something. Right? But the thought there is that there's some abnormal T1 shortening in the gray matter in a patient with Parkinson's disease. And when you see it down in the thalamus, right, you can actually see that rim is a circular rim, and we call this the bubble sign. So when you have like these dark areas in the thalamus that have these circles around them. So I think we've scanned about 5 Parkinson's patients. Tracy Meltzer scanned them down in Christchurch, and they've all had these little bubble signs, and they've all had these little extra rim signs. And these are in patients where we're not seeing anything in the substantia nigra. And yeah, sure, you can do a susceptibility way-to-scan in the brainstem, and it can take 25 minutes if the patient lays still. But like Parkinson's patients tend not to lay still. So it's a very hard thing to do. But this is a 1.5 minute, 2.5, 3.5 minute sequence. So we think it might have applicability not just in diseases that raise T1, but also diseases that can lower T1, like Parkinson's would. So moving forward, and I'm almost done here. So moving forward, we know what we think we want to study, and we know what questions we think we want to answer. And I think I've asked most of those questions and said I don't know what the answer to those questions are. So we've been funded by you to do, it's still a primarily protocol development study. It's to make these not be anecdotal, but have a larger number of patients that we can look at these findings in, and also follow some of these patients over time to see if the imaging findings change with changes in symptoms. So we're going to recruit patients both here in Auckland and also in Gisborne. We will recruit more patients in Auckland than in Gisborne because there's a larger pool of patients up here than there is down there. And we're going to try to get some on first presentation. We're going to try to get some who are established patients just to see if we see the findings in those patients. And then in the ones that are first presentation, we'll follow them at a couple of time points. And in the patients that have established disease, we'll follow them if the symptoms change and see if the findings on the scan change. And we'll be recruiting across multiple subtypes of MS, including and also NMO. And to do that, one goal is to get a little more pilot data so that we can go for a larger grant. So to do a 2 or 3 year prospective study is several $1 million, but you need pilot data. So we want to get the pilot data from here. But also by scanning in Gisborne, which is on a GE machine, and doing some of the patients up here at Camry, that's a Siemens machine, and maybe doing some at one of the private centers that has a Philips machine. By the end, we hope to have robust protocols that will work on all 3 major vendors. So we can not only just then use the pilot data to do a longitudinal study, but also we can start disseminating this to other places around the world. And I mean, I know there's more than 3 vendors, but if we can just get it working on the 3 major ones, it'll be a really, really big step forward. So we're probably going to do about 30 to 40 participants. I talked where the recruitment is. We've set up an email at Mātai. It's just ms@matai.org.nz. And if anyone's interested or has a comment, or if someone wants to be a volunteer or has anything they want to say about this, then please email here. For a while, I'll be the only person checking it, so it might take a while, but we will try to get back to people. And then if you want to know more about other work Mātai's doing, Lisa's one of our stand up, Edwin. She's running a booth outside, and she can tell you a little bit more about what Mātai's been doing. So that's my summary. I hope you not only know the pictures we're getting and why we think it's exciting, but also maybe understand why it does that, because then it might stick with you a little bit longer. And we can do questions now or after Benson's talk or whenever anyone wants. But thank you all for your attention. It's a pleasure being here.
Thank you, Dan. Very clear. We'll take questions after.
Okay, where do I go now?
You can see why there's a lot of interest in this process, and Benson's interested. Benson is one of our rising local stars, an Auckland graduate, did his neurology training at Auckland Hospital, and then undertook subspecialty training in neuro-ophthalmology, first at Emory University in the US and then at Cambridge in the UK, where he completed his PhD. And he came back to New Zealand last year, just getting established. He's a neurologist at Auckland Hospital, does general neurology, but has a particular interest in neuro-ophthalmology, where he runs a clinic with Professor Helen Danish-Meyer. And Benson, I'm pleased to say, has a particular interest and expertise in MS. And in his role as Senior Research Fellow at the University of Auckland, he's able to do research studies of the sort that we've discussed. He's going to talk about his favourite part of the brain, which is the optic nerve.
So thank you very much for the introduction, Ernie, and what a pleasure it is to be able to have, I guess, a conversation tonight about several conditions that I look after, but things that are particularly relevant to what Dan's talked about, and essentially how we can use the eye to understand what's going on with multiple sclerosis and try to understand how we can measure disease activity and potentially look at new treatments as well. But the title of my talk tonight will focus on not only multiple sclerosis, but Dan alluded to it before, talking about NMO. So we'll have a chat about what NMO is, as well as MOG or MOGAD, and have a think about how these different conditions might present with optic neuritis and how we can tell them apart. So I guess the first thing to say is, well, why do we talk about MS, NMOSD, and MOGAD? Well, over the last 15 years, there's been a massive explosion of knowledge about MS and the potential disease mechanisms that underlie multiple sclerosis. And at the same time, we've known forever that there's been a lot of diseases that can mimic multiple sclerosis, but aren't actually kind of the MS type. So, favorite organ is this one here, the optic nerve, this bit over here. And the optic nerve is really interesting. And actually the reason why we kind of joke about the optic nerve as being part of the brain is actually embryologically, the optic nerve is actually an outpouching of the brain. So it's got the same tissue as brain. It's not it's not part of the eye, even though it sits at the back of the eye. It's very much part of the brain. So multiple sclerosis and mimics of multiple sclerosis can all affect the optic nerve and cause optic neuritis. So diseases such as MS, MOGAD, and NMOSD can become challenging to diagnose when a patient presents with optic neuritis and they don't have an established diagnosis of MS and we're not quite sure which disorder it is. It's important to get the diagnosis right because we're now understanding that each of these three conditions have different outcomes and also different treatments as well. And even if we treat someone with MOGAD, with MS treatment, we may not necessarily prevent their disease activity from getting worse, or we may actually observe that they have continued attacks of optic neuritis or other focal neurological symptoms. So, a quick look at the optic nerves. The optic nerves are obviously these bits here, okay, sitting behind the eye. They're an outpouching of the brain, about 5 centimeters in length, and at their thinnest point, they're around 1.5 millimeters, and at their thickest points, up to 3.5 millimeters, so very tiny organs. Often I say to the patients, if you're thinking about the optic nerve, it really is that sort of stringy bit at the back of the eyes. So, these bits. So, what happens with optic neuritis? So I've represented here inflammation. It's a word that we throw around loosely, but what does it actually mean? We're not quite sure. But if someone has an attack of optic neuritis, as many of the people in this room would have experienced, what does that look like? Well, here's an example of what a normal visual field might look like, where you can see the image nice and clearly. There is no loss of the visual field or sort of spots within the vision. But in someone with optic neuritis, you can see here that this person centrally, we've now got a big fuzzy blurry spot over here as well, okay? So optic neuritis really refers to inflammation of the optic nerve, and typically that presents with vision loss and presents with pain, particularly pain with moving the eyes. So let's just have a refresher about optic neuritis and multiple sclerosis. So in MS, optic neuritis typically involves only one eye. Patients will present with pain with eye movements, and generally the blurring or loss of vision is accompanied by loss of color vision as well. Optic neuritis usually only involves a small area on MRI, conventional MRI, so not UHC. And for some patients, if they haven't had any prior symptoms, they may actually have some incidental lesions that are discovered on their MRI scan. So here we can see an example of a patient with optic neuritis involving the left optic nerve. So the image doesn't project well, but hopefully you can appreciate that there's a bright spot there within the optic nerve, which is this big line over here. So this bit over here that you can't see on the right side. What are the lesions that might be detected at the same time? So in patients with multiple sclerosis, Dan has sort of given us examples, but here we can see the locations of lesions that we typically see in MS, the bright spots there, and also these lesions here, or Dawson's fingers as well. So I won't sort of go into too much detail about what do we do in clinical practice if someone has optic neuritis and we incidentally detect these changes, because that's, I guess, another sort of discussion for another day. But regarding the optic neuritis, we know that after an attack of optic neuritis in MS, the visual recovery is generally over several weeks. The visual prognosis is generally very good, but a lot of patients will experience residual symptoms, including desaturation of colour vision, so things might look washed out or not as vibrant or sharp. And patients can also often experience glare and light sensitivity, and certainly like other MS symptoms, if you're tired, run down, if there's other things going on, your vision can fade or grey or even black out for a short period of time. So what's MOGAD or MOG? So MOGAD or MOG refers to myelin oligodendrocyte glycoprotein or MOG related antibody disease. So I like to think about it like Judith Kerr's Mog the cat. And like Judith Kerr's Mog, Mog likes to come back. The cat always comes back. The cat also does silly things like attack different parts of the nervous system. And in particular with MOG, the specific antibody represented by this Y-shaped fork over here that you can see in orange, it makes its way past the blood and brain barrier and attacks the oligodendrocytes. So the oligodendrocytes, which are here in blue, are a special type of cell which support the structure of the neurons and in particular are really important for producing myelin that lines the surface of the neurons. So you can imagine if the immune system is activated by this little antibody, MOG, and it attacks the oligodendrocytes, essentially a lot of the myelin gets lost and the immune system can get activated, resulting in further damage as well. So, like multiple sclerosis, MOG can also attack the optic nerves, the spinal cord, and also other parts of the brain. We still don't fully understand the disease mechanism that underlies MOG. We don't fully understand why the antibody is produced. We also don't know why the antibody has a way of getting into the central nervous system. But in recent years, especially with coronavirus, we've observed that often MOG can develop after an infectious disease. So like Dan was saying before, if you have some sort of infection or illness, whatever that infection or illness might be, it might prime the immune system to producing antibodies if the MOG, for example, gets exposed to the immune system, and as a result, that antibody recognizes the protein on the surface of the oligodendrocytes and leads to further damage or destruction. So, what does optic neuritis in MOGAD look like? So, unlike optic neuritis in MS, MOG typically presents with bilateral or vision loss involving both eyes. And in contrast to optic neuritis related to MS, the vision loss tends to be a lot more severe. Often there's a lot of swelling and inflammation, here inflammation again, and here you can see represented examples of the optic discs at the back of the eyes. So if we took a photograph of the back of the eyes, and you can get a lot of photographs, even just going to see Specsavers, they can show you your optic disc, the front of the optic disc, which appears as a circle, and here you can see that there's inflammation and swelling of the optic nerves. And so this is very typical of optic neuritis in MOGAD. Unlike multiple sclerosis and the optic neuritis that we see there, in MOGAD, the MRI often shows long segment of inflammation. So here's a patient that I saw when I was in the US. I think she was a 27-year-old woman with severe vision loss in the left eye, and she quickly developed vision loss to no perception of light over 2 or 3 days with intense pain with eye movements. And here on the MRI, very obvious, a long segment of inflammation involving the optic nerve where you can see that it's bright and it's very swollen. So over here you can see that as well. And the front of the optic nerve, where we saw that little circle before, this bit up over here, you can hopefully appreciate that there's a bit of swelling there, which is what we see over here with the front of the nerve being swollen. Interestingly, even though it looks very aggressive and angry on the photographs and on the MRI, optic neuritis in MOG is very steroid responsive. So often patients will recover vision very quickly after 1 or even 2 doses of high-dose IV methylprednisolone. But interestingly, these patients often have a very high rate of recurrence. So if they come off the steroids too quickly, or we don't have other treatments available to suppress their immune system, these patients will often have very, very frequent and recurrent attacks of optic neuritis. So what's NMOSD or NMO? So NMOSD refers to another group of disorders also known as neuromyelitis optica spectrum disorders. Unlike MOGAD, which we've only known about for the last 10 to 15 years, NMOSD we've known for probably as long as multiple sclerosis. It's been known under various names: Devick's disease, opticospinal multiple sclerosis, NMO, but more recently the sort of standardized name is neuromyelitis optica spectrum disorders, recognizing that there are a number of presentations, a number of sort of symptoms that people can get, and the diagnostic criteria reflects this because it requires the identification of another antibody called aquaporin-4 or AQP4. So in contrast to MOG the cat, AQP4 is also found, well, the aquaporin-4 antibody is also developed in the bloodstream and makes its way across the blood-brain barrier, but in contrast to MOG, where it was attacking the oligodendrocytes in blue, with aquaporin-4 antibodies, they attack the astrocytes, the cells here seen in purple. So the astrocytes themselves have a very unusual function. The astrocytes here you can see on the screen have long legs with little feet, and essentially the feet are there to provide a barrier or a form of protection as part of the blood-brain barrier. And so the blood-brain barrier is really important because we really want to prevent components of our immune system from reaching the central nervous system, because essentially, as we see in multiple sclerosis, immune attack across the blood-brain barrier results in inflammation again of the central nervous system. But in this situation with aquaporin-4, it attacks the astrocytes. The feet of the astrocytes, also known as podocytes, essentially break down and allows the immune system to enter through the blood-brain barrier, resulting in inflammation and damage to the support structures that are there. So again, like multiple sclerosis and MOGAD, NMOSD can attack the optic nerves, spinal cord, and also other parts of the nervous system, but with distinct syndromes, which we'll talk about very briefly. The other sort of important thing to recognize is that NMOSD can also be associated with autoimmunity against other diseases as well. So how does optic neuritis in NMOSD present? Similar to MOG, often it's very rapid, severe vision loss affecting both eyes at the same time. Again, like MOG, it can also cause long segment, very inflammatory swelling of the optic nerves, as we can see here in this patient with a right optic neuritis. And it's very obvious here, this very big, long, swollen optic nerve over here. Interestingly, in contrast to MOG and MS, the optic neuritis in NMO is usually poorly responsive to steroids and often requires specialized treatments to remove or filter out those antibodies that are there. So how are they diagnosed? How do we recognize the differences between MS, NMOSD, and MOGAD? So the pattern of findings on MRI differ in the brain and the spinal cord. So here on the left side of the screen are examples of typical lesions where we would see them when they occur in multiple sclerosis. On the top panel here to the right, we can see the typical lesions that occur in NMOSD. And so here you can see this big lesion in the back of the brainstem in an area called the area postrema, and it's well recognized that patients with NMOSD can sometimes present with not, vision loss or problems with arms or, weakness of arms or legs, but patients with area postrema syndrome can present with intractable nausea or hiccups. And so that's not really a typical neurological presentation, but something that's been observed in patients with NMOSD. In the bottom panel here, we see examples of MOG and the kinds of changes that we see on MRI. MOG in itself also has a variety of presentations depending on whether or not you're a child or an adult, but here you can see that the lesions, in contrast to the lesions of MS, tend to be very big and fluffy and, cloudy here like that, so big fluffy patches. So looking at the MRI scans of the brains can help us differentiate between the different conditions. But additionally, looking at the spinal cord changes are also very useful as well. And I won't go into detail there about where the lesions are typically located. The mainstay and the main thing that helps us make these diagnoses is to identify the presence of MOG or aquaporin 4 on blood tests. But these methods aren't exactly 100% accurate either. Often blood tests, the sensitivity on blood tests may vary, and for some patients we often require testing in cerebral spinal fluid as well, which leads to lumbar puncture. So with these patients, sometimes we also need to perform a lumbar puncture as well to look for different components. So why is it important to get the diagnosis right? So as I said before, without treatment, MOGAD and NMOSD are often associated with high rates of relapse. We can use treatments to prevent attacks of MS, MOGAD and NMOSD, but the long-term treatments, the preventative treatments, are usually very different. And I won't go through that, but just to say that, with NMOSD, there's also lots of new drugs in development as well. Important to mention that with MS treatments, if we treat someone with MOG or NMO with MS drugs, it's been observed that for some treatments, often things don't work or in fact can make things worse as well. So right diagnosis, right treatment, better outcomes. Okay? Right, let's talk about my favorite organ again, the eyes. And we'll link this in with Dan's talk as well, because I think you'll find this very interesting. So optic neuritis, as I've hopefully convinced you, can be a very early clue as to what might be going on. You've seen that NMO, MOG, and MS can all present with variations on MRI scans, as well as clinical symptoms. They can affect the optic nerves in subtly different ways. But the very exciting thing is that in ophthalmology, we now can recognize different signs of these diseases in the back of the eyes. So the eyes are not really window to the soul, but to the brain. And so how can we do that? So a lot of the techniques that I'm just going to be talking about in the next couple of slides are actually already available. If you go to Specsavers, if you go to your optometrist, you can get these images done, you can get these scans done. But at the moment, like what Dan alluded to, we don't know how to interpret what are these findings and what's the significance and what's the predictive value of some of these sorts of things. So the first thing that we can get is just a standard fundus photograph. So if we look at the back of the eyes, we can see the optic nerve there in circle, kind of like a egg here with the blood vessels running out like spider legs. And then the bit here, the dot, is the macula, which is this very important central part of the vision. Technology in ophthalmology has advanced to the stage where we can now take cross-sections of the retina and the back of the eyes. So if you imagine if we sliced a line horizontally through the optic disc, through the macula, through the retina, and then took a cross-section in the layers beneath here, this is the kind of image that we're getting. So draw a line through here, and looking at the back over here, the image is unfortunately flipped, but the optic disc is actually on this side over here, where you can see the nerves basically running down here, the big white thick bit here, and then this little dark bit here is represented by the fovea over here. So the optic nerve is this big white bit over here, the fovea and the macula are essentially these bits here. What's really exciting, I guess, to say is that we know that the pathway from the optic nerve to the brain arises in these top layers over here, the retinal ganglion cells. So if we look at this patient here who's had optic neuritis, initially when they're presented with optic neuritis, here you can see the photograph shows swelling of the nerve over here, swelling of the nerve, where the edges of the nerve are not crisp and clear, they're kind of blurry and fuzzy. And on the specialized scan that we've got here, essentially we've just got the computer to measure the thickness of these top layers up over here. So measuring how thick the layer is over here, we can then quantify what's going on at the back of the eyes. So with this patient, because the optic nerve is swollen, we can see that it's swollen. The numbers here turn white because they go above the normal of green. But what we understand about optic neuritis is with time, the swelling starts to subside because there's been damage to the optic nerves. The optic nerve starts to shrink down and it starts to go pale, as you can see on this bottom picture over here. But if we were to follow this patient and perform the optical coherence tomography, or OCT, this special kind of scan, several weeks after the attack and much later on, we can see that there's progressive thinning and thinning and thinning of the optic nerve, but also the retinal ganglion cells that are in the back of the eyes, in the area around the macula as well. And I guess the exciting thing about this is that with all the MRI scans that we've been looking at, is very much a binary outcome. Is it abnormal or is it normal? Is it white or is it dark? Or is it different shades of grey? With optical coherence tomography, we've actually got a number. We can quantify the thickness of those nerves that are there. And what would be really exciting to do, and we'll have a chat about it afterwards, is how can we use this kind of technology, simply just photographing the back of the eyes, to correlate with what's going on in the brain, okay? So this is just a little, I guess, a snapshot of what's happening during optic neuritis. I don't have the slide for, I think I've taken it out, but there's sort of studies that have been done now in people with MS who haven't had optic neuritis, where we can actually detect these changes happening in the back of the eyes as well. And the reason for that isn't because they've had some sort of, attack of optic neuritis that was missed, but the retinal ganglion cells, which start off at the back of the eyes over here, retinal ganglion cells which start at the back of the eyes over here, make their way into the optic nerve. They then travel back of the eyes, make their way around to the back of the brain, to the occipital lobe. So if you've got MS lesions or plaques or scars or whatever terminology you like to use that's forming there, potentially we can develop, or potentially we can pick up thinning of the optic nerves as a reflection of what's going on in the brain. So in summary, MS, MOGAD and NMOSD are distinct diseases that have similar presentations. But because they all present with optic neuritis, early and accurate diagnosis is important because each disease has a different treatment. Research into the optic nerve as a target of immune-mediated attack by all three conditions will allow us to better understand these conditions, identify new biomarkers of disease, and hopefully develop new therapies as well. Thank you.
MS New Zealand Executive Committee considered MOG and NMOD at its last meeting because it features in the work of the Brain Health Organisation in the UK, and if you know that, that has been the basis of our advocacy. Hi Tim at the back. Tim Preston, the first chair of the MS Research Trust, welcome. They have recommended that there is a much greater correlation between clinicians who are diagnosing and working in the optic nerve and MOG and NMSOD and MS. And so it's going to form part of our advocacy as an organisation with government and with Pharmac and whatever. So obviously Benson will be in much closer contact over those things. But the first question for the panel, if I can ask it, Ernie, is to ask just how many people, do we know how many people have these diseases in New Zealand, and what treatments are there available, and are there things that Pharmac ought to be doing that they're not? So on that basis,
I'll let Benson comment, but they're not as common as MS, but they're not rare.
They're not as common as MS, but they're not rare. And part of the difficulty in having accurate numbers or to calculate a prevalence is that traditionally the way that we've diagnosed these conditions is to look to see whether or not they're similar to MS. And if they're atypical or unusual for MS, then we might go ahead and request an antibody test. So part of the challenge here is that if a clinician doesn't necessarily recognize that the patient might have another condition, they may not necessarily ask for the antibody test. Or if they ask for the antibody test, there's also a chance that the accuracy of the test is affected as well. So true numbers, difficult to say, but I think a very interesting study to do, certainly looking in the New Zealand context as to the prevalence of these conditions.
Right. Worldwide, what are the proportions of people with NMO and MOG versus people with MS? I mean, they've been around for quite a while now, so there must be some figures out there for it. Percentages?
Yeah, I'm not sure about the New Zealand context. I think in terms of, I don't know, Ernie, would you sort of roughly, I guess anecdotally, we definitely see probably, well, I think MOGAD is on the rise, I think because it's a condition that's only sort of certainly been recognised in the last 15 years. The numbers of MOG patients that we have, certainly in the neurology clinic, are a lot higher. But the other issue that we have, and to avoid answering your question, is that it also really depends on the setting that the patient's seen in. So as you would have seen there, the talk was focusing on, optic neuritis. The vast majority of patients with MOG are seen in the ophthalmology clinic, diagnosed with MOG, and they never sort of go on to develop any other symptoms other than recurrent optic neuritis. And it's only until the antibody test is done that we're clued up that it's MOGAD. NMOSD, I think, certainly much rarer than MOG. Interestingly, in New Zealand, NMOSD, we're seeing higher rates in Pacific peoples, Māori population as well. So there may be a genetic or ethnic predisposition to these conditions.
I imagine, as you described the NMO and breaking down the blood-brain barrier, I imagine that there's going to be quite a few comorbidities that are going to cloud the diagnosis.
Oh yeah, definitely. And NMOSD is often associated with things like lupus, with thyroid disease, other sort of autoimmune conditions as well. And so it's very often very difficult to sort of look after these patients because they require multiple specialist input, rheumatologists for their joints, endocrine for their thyroid issues, and other things as well. Rob.
Thank you guys for the talks. This is a question for Dan. With the ultra high contrast sequence, do common conditions such as like vascular small vessel disease, do you see that on that sequence that might confound your findings?
Yeah, so small vessel disease also causes the same changes in T1 and T2 as the other thing. So if you have small vessel disease, it looks just as abnormal as all the pictures that I've shown you. And I say when you interpret it, because there's no one else doing these, right? But I think if someone had a history, of small vessel disease, I think it would be very confounding on those images. And that might not be a person in who it would be particularly helpful. But the same issue would happen on the T2 flare, right? Because the white matter would be diffusely abnormal. But the changes look, it goes from black to white just like it does before, right? And it's really hard interpreting. It's really easy interpreting is a small vessel disease versus demyelinating disease, because if the referring clinician doesn't mention the suspicion of demyelinating disease, we just say small vessel disease, because something like 500 times more common, right? So where it becomes difficult is when the clinician then says, does this person have? And then you have to make sure that the person asking that question is someone who actually knows how to tell the difference, right? Because you can just have a GP that writes, query small vessel disease versus MS in everyone, and then that would be completely unhelpful, and we'd be wrong almost every time, right? Because we would just say we'd probably be right almost all the time, because we would just say small vessel disease in everyone, right? So see, I'm giving you both answers because it's really confounding in those situations.
That's true in the brain, but it's very useful still in the optic nerves and the spinal cord, where it really potentially make a big difference.
Yeah, so we tend not to see changes in the optic nerve in small vessel disease. That would be really, really uncommon. So we've actually started on our clinical exams to always add images of the optic nerves anytime someone questions whether or not there's demyelinating disease. And then rather than actually try to predict which one it is, that's a great way to make yourself look really smart in the small amount of times that you're lucky and make yourself look really stupid almost every other time. It's much more useful to say, you know, like there's white matter changes in this distribution and this is more suggestive of this. But the optic nerve changes are more suggestive of this, and the spine changes are more suggestive of this. And then I can kick it back to these guys, and then they can decide what it is. But they see the whole clinical picture, right? So like a good referrer knows how to use that result.
Yeah, so I think for clinical context for people in the audience, essentially the discussion is around dots or plaques or scars that show up white on the white matter in the deep parts of the brain. Often in medicine, radiologists will often see dots and spots that come up for other conditions as well. The most common being as one gets older and as you start to accumulate birthdays, little blood vessels in the deep parts of the brain will start to harden up. And when that happens, it can also cause little white dots and spots, which to a poorly trained radiologist or maybe an inexperienced radiologist might get confused with multiple sclerosis or demyelination or other things. So the question, I guess, is, how do we differentiate between those changes and what we're seeing on UHC with what Dan's found as well? So I think it's a really interesting point.
Can I ask the panel, having got our fluids flowing and salivating over UHC, I wonder if you wouldn't mind looking into your crystal glass right in front of you and suggest to us when somebody like me with MS might actually benefit from the work that Mātai is doing.
So this is really exciting. So I'm going to answer first, and be interested to hear your opinions. But I think the thing is clinicians, and I had a really great afternoon clinic this afternoon. Shout out to you guys. And one of the questions that came up, and I think it's really sort of pertinent and useful, is a lot of what we understand about MS at the moment is this idea or concept of active inflammation as well as this background inflammation or immune sort of attack. The sort of MRIs that we do at the moment are fantastic for picking up active inflammation. And so if new spots are forming or if the new spots light up with contrast, that's really useful to know because that means someone's potentially having very aggressive disease and we really need to step up our game in terms of controlling the MS. But for a lot of people with MS, you kind of reach the stage where you keep doing the scans and there's no more new lesions from forming, or certainly when you squirt the contrast in, none of them light up. But the patient sitting in front of us is continuing to have symptoms which are slowly getting worse. And in the clinic, we give that a label as maybe you've sort of turned the corner and now you've got progressive MS. But I think the massive advantage here with UHC is it gives us perhaps an understanding about exactly what the burden of those lesions or changes are, and potentially as part of the study, if we can find out whether or not there are distinct differences or can we do a scan with someone with progressive MS? Can we do a scan of someone who's early diagnosis with relapsing remitting MS? If you sort of looked at the scans and we didn't know which person was which, are there distinct features on the scan that would allow us to identify who is who? And I think this is where biomarker studies are really, really important. The whole point of doing a scan is to give us an understanding of what's going on in the head, to try and help us make decisions clinically about what we can do for our patients. At the end of the day, the aim is to sort of halt MS, stop disease progression, prevent disability from accumulating. And so if we've got the tools to be able to do all of that simply based on a scan, I think that's a very powerful thing.
That's hard to follow. I mean to go after you. That's hard to. So I will tell you what I would like to see out of this, okay? And I view it purely from the diagnostic side because I'm not involved in the treatment or the clinical follow-up, right? Because I sit in a dark room all day and look at a screen. I would like to see someone comes in at initial presentation, right, and the standard sequences show you the permanent damage, right, but the UHC shows you the reversible damage. So the more reversible damage there is, the better you may respond to treatment, right, because they're causing symptoms, but they're reversible. I'd like to see it have some benefit like that, right? Or I'd like to see that someone comes in with a disease flare and you see the diffuse inflammation. And then you know, okay, this person is probably going to respond if we can get rid of that diffuse because there's no new permanent lesions. So like that's kind of the biomarker predictive I'd like to see come from this. From the people who are involved in this study and development, they'll start using it in their clinics really, really fast because when people think they're onto something, they like to implement it. And we know this because we have clinicians in town who want to treat concussion patients based on those images I showed you of concussion patients. But, you know, they go to ACC and ACC says, what the hell is this? You know, we've never seen this before, right? So the people involved in this study will probably start using it soon. How far until, like, it's a nationwide thing? I mean, you're probably what, say 5-7 years at a minimum, right? Just because you've got to really validate it, and you've got to convince other people who've never heard of it that are not working on it to validate it. But I imagine that Auckland area people will benefit from it much, much sooner because people like Benson are working on it and they're aware of it. And since they're working on it from the beginning, they're aware of its limitations, they know what's been shown, they know what's not been shown, and that'll disseminate into that group. So locally, sooner. Globally, a bit longer.
So, if we all went out and bought our own MRI machine, it's not going to have to be faster.
Probably not. If you want to buy us some more MRI machines, we'd be great.
You'll be interested in your take. You've been in the game a long time. And I know you're...
My take is that for many people here, the thing we need is treatment for the low-grade progression, which we don't have. And part of the trouble is that we don't have the tools to assess what's happening in that situation. Clinically, it takes a long time. You know, the changes occur over months or years. What we need are imaging modalities that show us the subtle changes in this progressive disease, which I think UHC and related sequences potentially give us a chance to actually get trials done more rapidly to find treatments that actually work. Because running a trial currently to see if you're changing low-grade progressive disease is a minimum of 2 years with very dodgy measures to pick up what you're changing. It's very gloomifying, actually, but better scanning techniques that would show progressive disease, I think, is a big opportunity.
There's not a role for PET-CT with the UHC MR or PCMR even.
So not with PET-CT, because we can get the PET images, but not the MR images. I would love to have a PET MR to do the study on, because then you can use all the inflammation tracers that are available with PET, and you can then combine them with these techniques, and you know the resolution is still sub 5 millimeter, sub 3 millimeter. So we, like, I keep telling Lisa that, like, you know, and I tell my board at Mātai that if they don't buy me a PET MR, I'm gonna die. And they just kind of laugh at me. I'm like, but I want a PET MR. So like this, I throw a little temper tantrum like a little baby. But no, like this is the kind of stuff that where PET MR would have an advantage over PET CT.
And what is the functional MRI? I thought the functional MRI was being developed to deal with PIRA, which I think is what you were talking about, Ernie, in the measurement of. What is that in comparison to the ultra contrast one?
No, it doesn't really answer the question that relates to low-grade progression in MS. It really relates to acute function of something that you're doing at the time the tracer is given on MR. So it's more like if you're thinking about a holiday in Tasmania or something, and which part of the brain lights up.
I'm sorry, I might have missed it, but the MOGAD and the NMOSD are something I'd never heard of until a few days ago. My question is, are they reversible?
So It depends on definition of reversibility, but for MOGAD and NMOSD, MOGAD itself, the treatments that are available, we don't have anything specifically targeting the antibody. For NMOSD, the antibody was identified in 2004, and since then there's been a number of large clinical trials to similar to the drugs that we use in MS, but a very different mechanism. And for a lot of patients on these very highly effective treatments, the rate of disease activity and relapses does go down, but it's not completely, eliminated. MOGAD, much more aggressive in terms of its reoccurrence, but intriguingly, and we still don't understand why, about 50% of people who have MOGAD, they have a one-off illness with one attack and they don't have further recurrence, which leaves another 50% who have recurrent attacks that are often very steroid responsive, so we keep them on steroids for a very long time, but because we don't have specific treatments available for MOGAD, often it requires a lot of trialing different kinds of immunosuppressive medications to see which one works the best. And a lot of these patients often end up on long-term steroid doses, not very good, and there's always the worry that the symptoms will reoccur.
There's another important point about those two antibody-triggered diseases, that they don't develop, by and large, the low-grade progressive changes late in the course. And that's a very intriguing aspect that seems localized to MS. We also think that there are a number of other antibody-mediated diseases like MOGAD and NMOSD that we have not yet found the antibody for. And some of them may be separable from MS in the future too. It's an evolving field.
Tell me, as a complete layman, the OCT, the optical tomography machines that the ophthalmologists use, how is that work enhanced or otherwise by the ultra high work that you're doing with the MRIs?
Yeah, so I can probably talk about the OCT, but Dan can speculate about the correlation. So optical coherence tomography is kind of the equivalent of using infrared to segment the different layers of the retina. And it's very commonly used in the eye clinic, but what it allows us to do is to quantify the amount of retinal ganglion cells that are there, which are essentially the big neurons whose axons or tails join together to form the optic nerve, and then those big long nerves then travel into a different part of the brain, connect with a whole lot of other nerves that then wrap their way around. So what we're beginning to understand about OCT, and it's not just for multiple sclerosis, it's, I think, sort of the field of neurodegenerative diseases, so things like Alzheimer's and Parkinson's, is that as the brain starts to become affected by these different neurodegenerative processes, and multiple sclerosis is included, I guess, in this sort of group as well, if there's any sort of lesions or disease that involves those big tracts or visual pathways leading from the eyes to the brain, we can basically detect that thinning that's occurring in the back of the eyes. Now, to your question about how that might relate to what we see on MRI, is that there have been studies that show that if there's a big lesion caused by MS sitting, say, in the back of the brain in the occipital lobe, clinically that will cause visual symptoms. Half the vision is lost in both eyes. But on OCT, the area of thinning is actually half the eye as well on both sides. And there have been some studies where they've basically taken big cohorts of patients with multiple sclerosis, performed OCT at different time points, followed them over 10 years, and we understand that in people with a history of optic neuritis and also people with MS without a history of optic neuritis, the degree of thinning in the back of the eyes seems to correlate. It's not a perfect correlation, but seems to correlate reasonably well with brain volume, the amount of brain tissue that's there. But at the same time, there are some indications that the amount of thinning in the back of the eyes is important for predicting visual prognosis, how well someone's vision will recover. But more importantly, there's been some interesting signs and studies, interesting studies which seem to indicate that the amount of thinning in the back of the eyes, irrespective of whether or not you've had a history of optic neuritis or not, seems to also correlate with MS disability in 10 years. So very useful thing to see what's going on in the eyes correlating with the brain.
Do some of those diagnostic techniques overlap for people with stroke as well?
Yes and no. So generally with stroke, because the symptoms are very clear cut, we generally don't need to sort of monitor thinning and changes in the back of the eyes. Usually in patients with stroke, the symptoms will, most often they're not declare themselves, and we can sort of pick things up with much, the scans, much easier to pick up stroke than it is to detect, a very subtle lesion in MS.
Sorry, so with OCT, it's more for like prognostication rather than like being able to differentiate acute lesion, subacute lesion.
Yeah, so we haven't got to the stage yet where we can reliably call the disability bit. We basically need more studies to do that, and internationally there's a big cohort called I'm Visual, basically neurologists and neuro-ophthalmologists interested in the eye and how it relates to MS, sort of doing big cohort studies where you basically scan everyone's eyes, you scan everyone's brains, and then you try and predict what happens over time.
Yeah, so I'm going to guess that the OCT is a much quicker procedure than an MR.
It takes about 5 minutes to do the optic nerve and another 10 minutes to do the retina.
Okay, so it's about 15 minutes.
Yeah, about 15 minutes.
But there's not the prep, and it's not in a bore, and you probably sit in a chair. And
you sit in a chair, you put your head into the thing,
something.
and then you take
so,
a photo.
So I'd be very interested to see, you talk about the studies where they tried to correlate the changes with a lesion in the brain. Yeah. But I'm sure there were cases where they didn't see a lesion in the brain, and I'd wonder if maybe with the UHC you might see a lesion, and that might help the correlations.
I think so.
And it sounds like, if you can show that those photos can give you the same predictive information as knowing where the lesions are, then you can potentially see more patients in an easier setting. Now everyone wants their test to be, the one everyone uses, but like if an easier, cheaper one correlates with the results of your test, then you do the easier, cheaper one.
And then you'd use that test then to confirm with the MRI scan. So I think there's a lot that we can do together to work on this.
I had a question for Dan. I'm interested in the general white matter whiteout, which occurs with a good dose of methamphetamine, a bump on the head, touch of coronavirus. So it suggests to me that that's just a non-specific effect, probably subtle edema of any sort of brain insult. And I would predict that in MS you have a hot plaque in one part of the brain just as a relapse. That would probably be enough to trigger the non-specific whiteout and the rest of the white matter temporarily.
Potentially, that's what we think. But so what I'd like to do with that whiteout is, honestly, I'd like to take people who have just done like residents in the hospital who've just done a 36-hour shift and who are thinking all foggy, and I want to scan those people because we do. Well, because we talk about, we haven't talked about like lymphatic systems or drainage of toxins or whatnot, or things that clear areas of inflammation. Right, and we know that lymphatics work when you're sleeping. So let's take a bunch of sleep-deprived people, who you work for 36 hours. It's like you're drunk driving home, right? I mean, and you after sleep deprivation, you don't function normally at all. And I want to do it in those people. But the problem is, they'll get in the scanner, they'll fall asleep.
I think we're probably done there. Oh, sorry.
Yeah, the question with you, did I hear you right that you're getting the benefits of the ultra high contrast, just configuration of whole technology?
Yes, so
the battle seems to be on the biggest and best.
Yeah, okay, so the ways these sequences are made is we literally run, and I'll be a little technical here, but I'll go back and say, the ones where we showed that whiteout sign, we run 2 fast spin echo inversion recovery sequences. And those are the sequences that were invented back in 1981. And on a newer scanner, they might run faster, and they might run with higher resolution, but all MR scanners since the first one could run those sequences. And then you take the images and you run it through a little piece of MATLAB code that takes 5 minutes, and you get the UHC image. So like on our scanner at Mātai, with all the research stuff that's not available to purchase yet, we could do it faster. But on my old scanner at the hospital, is 15 years old. Before we replaced it, I could run the same sequences. So what we're doing is we're using old acquisition techniques, and we're honestly being a little clever with some arithmetic of the images after the fact, and taking advantage of some physics that has been around for 50 years, but people haven't thought about it in a specific way. So these images, pretty much like I'm sure you could find some that's not going to work on, but for any reasonable place that's got a clinical scanner in New Zealand, you can make the images.
So what's it going to take the industry to do to using ultra high contrast variant?
Well, one, we have to prove that it works, and then it's predictive in that it actually does something, right? And then it's a matter of just getting people interested and showing them how to do it. I'm not the one that calls on people. You call on people.
Sorry, was there a question there?
She was volunteering.
Oh. Okay, can I draw the formal part of this session to a close? And I want to formally thank the speakers in a minute, but please, you don't feel that you have to race out into the dark, into the traffic. Stay and talk. The speakers will be here for a little bit longer. Interrogate them. If you want to talk to the trustees of the trust, we're all here and happy to take any questions. But I do think that we've heard tonight from 2 very enthusiastic speakers, and the enthusiasm that they have for such a complex and complicated subject is admirable. Looking at MRIs of the brain all day would drive some of us to drink, and it's good to see that both of them up here still sober at 9 o'clock at night. But I also just want to pay tribute to Ernie Willoughby, who has so successfully introduced the speakers. Ernie has had a career in neurology at Auckland Hospital, and I'm sure that Benson would agree that, and others in the audience, Zoe, that his commitment, one, to research, and his commitment to teaching young emerging neurologists has been one of the reasons why they're in neurology today. And we should be extremely grateful that we've had somebody who's been so committed to the public health service. So thank you, Ernie. I also just ask you to once again show your appreciation both for Daniel and Benson for their engaging talks, their very interesting talk, and the way in which they've been able to reduce quite complex medical and clinical issues into something that some of us have probably at least been able to understand 50% of. So thank you. And it's been really great wearing another hat as president of MSNZ to have the representatives of most of our regional societies here from Southland in the south right through the country, and it was too good an opportunity of you being in Auckland not to expose you to what we're doing in the trust and to give you some idea of some of the really exciting things that are happening here in New Zealand. So thank you all.